And thank you, Axel. Thank you, David. It's a pleasure to be here again and talk about optimal sequencing of agents in HCC in the era of immune therapy and novel agents and targets. So these, just to go quickly through the landscape of treating HCC just in with level of evidence according to stage, but we know at least for level of evidence one, what we have in treatment of advanced HCC, sorafenib, lenvatinib, regorafenib, and cabozantinib. Level 2, with a question mark, actually, are the immune therapeutic agents now, nivolumab and pembrolizumab. Sorafenib was established as our standard of care now for close to a decade in the first line after having no options whatsoever for patients with advanced HCC. This became our first standard based on initially a phase 2 study led by Dr. Abu Alfa, which led to this phase 3 study that ultimately established the role of sorafenib in HCC and has become our standard for quite a while in the first line, and we didn't have much any more options than this. Sorafenib had been challenging because of its toxicities and dosing, similar to a lot of these TKIs where we're challenged, especially in patients who have some baseline liver disease. And a number of trials actually tried to look at similar agents or try to enhance the activity of sorafenib. And unfortunately, all of those ended up being negative. Again, another study led by Dr. Abu Alfa with sorafenib plus doxorubicin, 80802 CLGB, just published in JAMA Oncology. Unfortunately, did not show that doxorubicin adds value to sorafenib. That was actually a very important study, I think, just from the fact that it does show that doxorubicin probably does not add much value in this disease overall, period. As you know, before sorafenib, doxorubicin was pretty much a standard, a poor standard for us, but we had essentially no other options. And I think this validated that chemotherapy perhaps does not have much of a role in this disease, and it's primarily biologics and perhaps immunotherapeutics. And there were others that looked, unfortunately, again, all of them ended up being negative. We'll touch upon lenvatinib, which is the other agent now that's approved and used in first-line treatment of advanced HCC. This was based on the REFLECT trial. The REFLECT trial was a non-inferiority trial powered for essentially showing that lenvatinib is non-inferior to sorafenib in terms of survival as a primary endpoint. And so as you can see, the median overall survival of lenvatinib and sorafenib were similar, so non-inferior, with essentially reaching its statistical predetermined primary endpoint. So that added another option for our patients with advanced HCC. The progression-free survival trended a little to favor lenvatinib, and the same for response rate. Now, keep in mind that these were secondary endpoints in a non-inferiority trial design, so be very careful how to interpret those. I mean, one can safely say that this agent is a safe alternative to sorafenib in the first line. That's as far as I would go. The toxicities are different. Lenvatinib, which is much more of a VEGF inhibitor than anything else, has primarily hypertension. Hypertension can be quite tough for some patients. 23% will have it more than grade 3. So it can be challenging in terms of management. On the other hand, sorafenib has its primary toxicity as palmar-plantar erythrodysesthesia, which certainly can be quite challenging. It tends to happen in the first month or two of treatment, and for some patients it can be quite tough to manage. So when we look at the results of the study and put this in perspective about what to do when we see our next patient with advanced HCC and the choices of lenvatinib versus sorafenib, so I think it's important to keep in mind the differential toxicities between the two. And when we look at essentially the discontinuation rate for adverse events, it's actually pretty similar between the two. So one cannot say that patients are withdrawing from one versus the other because of toxicities. If anything, a little bit more to the lenvatinib. Both agents had second-line therapy received on this trial at a rate of close to 1/3 of the patients. So how do we weigh the treatment decisions? I mean, this is challenging. Non-inferiority studies are very challenging to interpret because they really don't offer us the opportunity of understanding whether there is an agent superior. It just gives us an alternative rather than a replacement. Sorafenib has been really our standard of care for advanced HCC for a decade with a lot of challenges because of the toxicities. And lenvatinib, as I said, has been shown to be non-inferior. Secondary endpoints such as response rate and PFS, although seem to be better with lenvatinib because of the study design, should be interpreted with extreme caution. We talked about the side effects. I'll tell you, our biggest challenge is, frankly, since now we have second and beyond line options, and all these studies that we have on hand were actually in the setting of progressive disease on sorafenib and not lenvatinib. So the challenge is, of course, how do we interpret those studies if we decide to use lenvatinib in the first line? Would we still see the same outcomes for second line and beyond for those patients? Can we just extrapolate? And of course, this is a big question mark and should be taken a decision when deciding on how to treat those patients. And this brings us to the second line, randomized trials, and we have a number of them that essentially looked at HCC. I mean, since sorafenib was approved, we've seen an explosion of these phase 3 randomized studies in HCC, a lot of it, large activity, frankly, bringing a number of agents to a disease where we had zero before 2009. So in 10 years, a lot of work has been done and has brought a lot of good agents forward to treat those patients. So a lot of credit to the investigators who led a lot of these studies. So ramucirumab has been looked at. We'll talk a little bit about this in not just the next few slides, but the next discussion as well. Ramucirumab versus placebo was looked at in both REACH and REACH2 with alpha-fetoprotein more or equal than 400. There were studies with Brivanib, everolimus, that unfortunately were negative. The first study in the second line that essentially led to an approval of an agent was the regorafenib, the RESOURCE study, which looked at regorafenib versus placebo in patients who progressed on sorafenib. Again, it was interesting because the thought was regorafenib is pretty close to sorafenib in terms of its chemical structure, except for one molecule. So this actually ends up changing perhaps a lot the activity of the agent, and that's true when we look at colon cancer and GIST. There's certainly a differential activity between the two. Now, there is a caveat to the study, of course, is the entry criteria were a little bit restrictive, which could affect the interpretation of the study. Nonetheless, this study was positive for its primary endpoint of overall survival, same for progression-free survival, with actually reasonable hazard ratios. And there was even, using the median RECIST, there was a 10.6 response rate with regorafenib, which when applied to RECIST 1.1 was 6.6%. So we don't see a lot of responses with these agents, primarily stable disease. But this was positive and certainly placed regorafenib as an option in the second line treatment. And when this was published in, now I think, Lancet GI and Hepatology, looking at the sorafenib and regorafenib sequence for patients who received sorafenib followed by regorafenib, the median survival was close to 26 months, those that went on the placebo with 19.2 months. Again, to be interpreted with caution, given the fact that there are a lot of biases and selection issues that happen with interpretation of results like these, but nonetheless, it does show that with the proper sequence and with essentially exposure to at least 2 lines of therapy, we're starting to see patients with advanced HCC surviving beyond the 2 years, which is pretty impressive by itself, understanding that we were limited to less than a year just a decade ago. And then this study led by Dr. Abu Alfa, Celestial, looking at cabozantinib versus placebo in HCC in patients who progressed on sorafenib. So everyone had to progress on sorafenib, and then other, that study allowed third line as well as second line. So there were third-line patients as well as second-line patients included. The study reached its primary endpoint, again, with very reasonable hazard ratios, good deltas, and a progression-free survival actually was pretty interesting and pretty impressive. And earlier on, you see the drop in placebo and cabozantinib maintaining an advantage with the PFS over time, with a median PFS 5.2 versus 1.9 plus year. The toxicities of cabozantinib were not much different than expected. A grade 3 or 4 events. So again, PES primarily with cabozantinib, and hypertension as the main toxicities, with a little bit of fatigue and diarrhea. So very, very expected for this type of TKI that targets both VEGF and MET, and perhaps a few others. So that brings us to essentially another agent that also made its way to the treatment of advanced HCC. So the REACH-1 study, essentially, that compared ramucirumab versus placebo, or it's REACH, not REACH-1. Ramucirumab versus placebo took all patients and unfortunately did not show any benefit in patients who failed prior sorafenib. And then the investigators looked at a differential effect between those patients who had an AFP more equal than 400 versus then less, and they've seen trends actually favoring ramucirumab, which essentially led to this phase 3 study that selected patients specifically for those who had alpha-fetoprotein more equal than 400, and randomized patients accordingly to ramucirumab and placebo. And this study essentially reached its primary endpoint for overall survival and progression-free survival in patients who failed prior sorafenib, with the toxicities, as expected, primarily hypertension with the ramucirumab, and then hypernatremia, but primarily hypertension, which is expected for this. Ramucirumab has a very reasonable safety profile, unlike the other TKIs. And certainly for patients with HCC has now become a welcome option. For a lot of our patients, we're very reluctant to continue to proceed with more tyrosine kinase inhibitors beyond sorafenib and now lenvatinib. So unfortunately, this ends up being limited to only those patients who have an alpha-fetoprotein more or equal than 400, which forms less than 40% of patients with HCC. All right, now delving into the role of immune therapy, and this is a little bit more messy. Unfortunately. The excitement about immune therapy started first with this study that was ultimately led to the conditional approval of nivolumab in second-line patients with HCC. This was a large single-arm study, started with a dose escalation and then went to a dose expansion, including cohorts with uninfected HCV and HBV infected. The thought was that those with hepatitis virus infection may actually have a larger inflammatory milieu, which may allow them essentially to respond better to these immune therapy agents. It turns out that it doesn't really affect it. Those that respond. We don't understand why, and we still don't. And those that don't just don't. And there were two groups of patients, sorafenib experienced, meaning pre-exposed, and then sorafenib naive. Primarily the sorafenib experienced are the ones that were the larger group and ended up essentially to the approval of this agent on a conditional basis. The overall response rate across the board was about 20%, so relatively higher than expected for this type of disease, although keep in mind lenvatinib had a response rate above 20%. Now again, the responses tend to be less durable than what we see with the occasional patient with HCC exposed to an immune agent that actually responds. The median PFS, as you see, is pretty much in line of all other studies, which essentially means that the median, at least historically, this would not perform any better than any tyrosine kinase inhibitor on hand. It's being proposed that mostly those patients at the tail are driving most of the benefit, about 10 to 20% of the patients. So this essentially took nivolumab versus sorafenib in the CheckMate 459 study, comparing essentially nivolumab to sorafenib. This study that will be presented at ESMO was negative, meaning that it did not show that nivolumab would achieve a significant improvement over sorafenib, and with a hazard ratio of 0.85, and essentially in a non-significant fashion. So unfortunate, but in some ways, I hate to say that, in some ways, somewhat expected given the lack of selection. And the hazard ratio itself was not as impressive as we thought. I mean, one can argue that the medians perhaps would collide, but that the hazard ratio may actually favor more aggressively the immunotherapy agent, but it turns out it's probably not true. Now, we'll see the final results. There's a discussion that perhaps a lot of these patients who went on sorafenib ultimately crossed over to a PD-1 inhibitor. Again, we'll see. I'm not convinced at this point of time that for the large mass of patients with HCC, immune therapy should be our first and arguably maybe not even our second choice at this point until we understand where it lies. And that comes essentially at the heels of another study that was actually followed nivolumab pembrolizumab in HCC, had the same path to approval on a conditional basis based on this single-arm study, Keynote 224, which again did show a response rate of close to 20%, about 17%, durable responses, and then led to its conditional approval. But again, when we went to the phase 3, this was essentially presented with Keynote 240, randomizing patients to pembrolizumab versus placebo and best supportive care, keeping in mind that we do have active agents in the second line from all these other phase 3 studies. So comparing to placebo and not being able to essentially produce positive results certainly brings a big question mark about whether it would still make sense to expose these patients to the immune therapy agents versus agents that have proven to be superior to placebo. Now, there are a lot of reasons why this may have failed, but it is a negative study and certainly does show that both with OS and PFS, which were co-primary endpoints, the study failed to reach its primary endpoint. There's another agent, pembrolizumab, which also as a single-arm study with a large cohort has been showing, again, consistently these response rates that are interesting, but everything else looks pretty similar. So these are the agents, in summary, beyond the first line, and I just used the hazard ratio. I did not use the medians because, again, we keep on talking about the importance of the hazard ratios, perhaps, especially for immune therapy agents. And if you look at the hazard ratios for the TKIs and ramucirumab AFP above 400, they all look very similar, in the same ranges for survival, in the same range for PFS. And these are the responses below, and then the toxicities. And then when we look at pembrolizumab versus placebo, again, this is all historical comparisons, of course. The hazard ratio for survival was in the range, but for PFS, actually was not in the range of the other three studies. It actually, seems to underperform. And mind you, that they all were compared to placebo. The toxicities, of course, are different between all these, and the responses are the ones that remain a little bit more interesting with the PD-1 inhibitor versus placebo. So that certainly leaves us with trying to figure out what to do at this point of time. Our only level 1 evidence, as I said, is with these TKIs, not with the immune therapy agents. So Rego, cabozantinib, and ramucirumab for AFP more or equal than 400. So, there are a lot of reasons why the studies may have been negative. They share the co-primary endpoints, so they weaken some of the power. The median versus tail, I'm not buying that at this point of time. The hazard ratios are telling a different story, and even the curves themselves, when you look at them, don't look very different between the various agents. Overall survival is a challenge, and crossover designs, of course, but PFS is not impressive in any of these studies anyways. So, looking at perhaps thinking about more biomarkers, PD-L1 itself does not seem to select. CPS, I mean, there are hints that CPS and PD-L1 may select a little bit better, but they're really not differentiators. There are also and this was presented by Anthony El-Khoury, looking at perhaps some T-cell markers like a CD3 positivity, perhaps leading T-cell expressing CD3 leading the pack in terms of predicting for response. These have to be validated prospectively. There's also a lot of work that's being looked at in gene expression signatures that may relate to response. Again, all these are observations from the cumulative knowledge from those studies that have been presented, but unless validated prospectively, they don't have much value at this point of time. So where do we move next? And this is happening now. There are certain, and we'll talk a little bit more about this, but there are a lot of activity in trying to enhance immune checkpoint inhibition with additional CTLA-4 blockade, OX40, or the most interesting now are actually combining them with anti-VEGF combinations, and we have two examples of this, lenvatinib and pembrolizumab in a phase 1b study that show some really interesting responses and durability of responses, and the same with atezolizumab and bevacizumab, where the response rate was close to 30% with the combination of atezo plus bev and a favorable toxicity profile. And we're going to see actually the results. Hopefully, we're going to hear about the results of EMBRAVE 150, which compared atezo plus bev versus sorafenib. But a number of other studies are ongoing looking at a variety of combinations with lenvo, pembro, cabozantinib, atezo, and then dual ICI. So anyway, so this is probably how things are looking right now in terms of how to best sequence our patients with advanced disease. I think it's safe to say that for first-line sorafenib or lenvatinib, I don't think nivolumab fits for those patients here. And second-line, regorafenib, cabozantinib, or for those with alpha-fetoprotein more than 400, ramucirumab is an option. Not sure how to place pembrolizumab at this point of time. And third line, I mean, we can still consider the PD-1 inhibitors in case of that failure. I mean, these ongoing studies hopefully will salvage the field of immune therapy in this disease and will place them again more favorably in first and second line. Okay, thank you.